This conference will now be recorded.
All right, so we're going to cover chapter 28, head and spinal injuries. Tondra, yes, I saw your comment. If you want to bring a helmet in, that's perfectly fine. The more the better. All right. That would work too. All right, let's see here. So chapter 28. So we're going to have to meet the national EMS standard competencies as we've mentioned in every chapter so far. And we're going to put more of a focus on head, facial, neck, and spinal trauma. Looking at the management recognition of life threats and how to deal with a spinal trauma if we suspect one. We're also going to be doing in person the advanced spinal rule out. So Maine and New Hampshire spinal rule out is almost identical. Very, very, very close. So we're going to cover both of those. They're the main providers. Get the update for the Maine spinal rule out as well. We're also going to cover spinal trauma, pathophysiology, assessment, and management of, along with skull fractures. We're also going to look at penetrating neck trauma, laryngeal or laryngeal-tracheal trauma injuries, spine injuries, facial fractures, skull fractures, foreign bodies in the eyes, and we'll talk about dental trauma as well. We're also going to cover traumatic brain injury and spinal cord injury. So let's go back and talk about some, back to the nervous system. So the nervous system is a complex network of nerves and cells that enables all parts of the body to function, right? So the nervous system includes the brain, the spinal cord, and several billion nerve fibers that carry information to and from all parts of the body, right? So if you go to pinch your leg, that nerve transmits to the brain. You're going to say, "Ow, that hurts," right? So if you touch a hot object, step on a sharp rock, or whatever it may be, your nerve endings are transmitting sensation and pain through that complex system from that point to your brain, and then your brain back to your point of origin where the injury is, and says, "Hey, fool, take your foot off that rock," or "Ouch, this hurts. We probably shouldn't be touching heat." With that, because the nervous system is so vital, our nervous system is well protected. So the brain is protected by the skull, right? The spinal cord is protected by the bony spinal canal. So despite this protection, serious injuries can damage the nervous system. So we got to really look into our full in-depth neurological assessment. So the nervous system is divided into two anatomic parts: the central nervous system and the peripheral nervous system. And we're going to get that here in a second. So this figure here shows the two components of the nervous system, the central and the peripheral, as you can see in the diagram. And in the next slide, we're going to cover more in depth of the central nervous system here. All right, so we talk about an object or whatever it may be, so sensory nerve endings in the extremity, which then transfer through the peripheral nervous system to the central nervous system to the brain. The brain then correlates what's going on, it sends a message back through. So the message is sent to the brain and then back to that site again, as we were just talking about. So the central nervous system includes the brain and the spinal cord. The brain controls the body and is the center of the consciousness. The brain is divided into three major areas: the cerebrum, the cerebellum, and the brainstem. So this figure here shows the parts of the brain. So we talked a little bit about head trauma, the skull, the bones, and things like that. We talk about the frontal, the occipital, parietal, temporal. Those bones underneath there, if you remember the different lobes of the brain, is underneath that's the name of the skull. Like the frontal part of the skull is the frontal lobe of the brain. The occipital part, which is the rear part of your head, the back part of your head, you'll see the occipital lobe underneath the occipital skull, occipital bone. Then we have the temporal lobe, and then we have our parietal lobe. As you can see in the picture here, I'm trying to go a bit slower with the mouse now. This right here is the cerebrum through here. The cerebellum is a smaller part of the brain located down below, and the brain stem kind of sits here, right? So if we have a significant head trauma or a bleed pushing on here, remember, if we have a bleed inside, it's going to push the brain down this direction. I was kind of hoping. See, this actually works. So if we have a bleed through here, a lot of redness right here, this is our bleed, right? That pressure is going to push down this direction to the point where the brain stem, which is located here, can herniate and actually separate, causing significant loss of respiratory drive and other functions as well. Does that make sense?
Yes.
All right, awesome. All right. So the cerebrum controls a wide variety of activities, including most voluntary motor function and conscious thoughts. This contains about 75% of the brain's total volume and divided into two hemispheres with 4 lobes, right? So we have the right and left hemisphere. Let's go back to this picture here for a moment. So if you were to take, and this is kind of a bad picture for it. Let's see if there's someone coming forward. No, there isn't. All right. So if you take this, let's say the nose is aiming down this direction here, and you were to split from here to there, all right? Right versus left hemisphere. You could have head bleeds, traumatic brain injury, TBIs, bad enough to the point, or severe enough to the point where that hemispheric, where that suture line goes down the middle, that hemisphere is split. You can have hemispheric shift. So when you hear that word, like a hemispheric shift, you're taking one part of the brain that has all that blood and it's pushing it across the line, that suture, going directly across to the other side. Right, and that's significant brain trauma. Not a lot of people can survive that. And that can be as simple as a fall, mechanical fall to the ground, or just a vessel that bursts to the point it actually pushes that over. You'll see a lot of stroke-like symptoms. You also might see significant vomiting. There's a lot of different things that can change, and we have these types of patients. All right. So the cerebellum coordinates balance and body movement, where the brainstem controls most functions necessary for life, including the cardiac and respiratory systems and nerve function transmissions, which is best protected part of the central nervous system. And we talked about brainstem herniation, so we can have that significant trauma or a significant bleed that can actually cause a brainstem to herniate. If it does herniate at that point, that's when we're going to start losing our cardiac and respiratory system functions. So our brainstem controls the body. You know what I mean? So we talked about that already, which is why it's so important to make sure that we use cervical spinal mobilization, and also do the assessments enough to actually see if we see a change in vital signs and difference in status as well. So the spinal cord is mostly made up of fibers that extend from the brain's nerve cells. It then carries messages between the brain and the body via the gray and white matter of the spinal cord. Gray matter is composed of a neutral cell body and synapses, they're called. The white matter consists of fiber pathways. So with that, we have protective coverings. So the cell of the brain and the spinal cord are soft and easily injured. All right, they can be easily injured on any kind of traumatic injury. The entire central nervous system is contained with a protective framework, right? So this is where the cells of the brain and spinal cord are very soft, as we can talk about like severance of the spinal cord. So if that protective framework and the thick bony structures of the skull and the spine canal break or they fracture, it can actually cause either an impediment of that spinal cord, causing significant swelling, all right, or it can sever the spinal cord where it can no longer be repaired, right? So sometimes people have temporary paralysis and things like that because they have spinal shock and they have significant swelling of that spinal cord or this part of the spine. If that's the case, they can give steroids and anti-inflammatories and bring that swelling down. And eventually, you'll regain movement of the extremities and or the nerve fibers at some point. But if there's any kind of damage or severance of that cord is not rebuildable. This is also covered by layers of muscle and skin as well that helps protect this. So not only do we have the bony structures, we also have skin and muscle around it as well. The central nervous system is also further protected by the meninges and 3 distinct layers of tissue that suspend the brain and the spinal cord within the skull and the spinal canal. So the meninges, or meninges, is the outer layer. Let me go back a minute here. So obviously with this, we have the 3 distinct layers we talked about, right? That protect it. So the outer layer is the dura mater, which is a tough fibrous layer that forms a sac to contain the central nervous system. The inner 2 layers are called the arachnoid matter and the pia mater, right, which contain the blood vessels that nourish the brain and spinal cord. So let's look at this right here. Okay, we have our brain obviously down here. We have our different layers: the skin on the top, the fascia, the muscle. Then we have the skull, which is the inner table of the skull. That's our bony structure that protects our head, right? Then we have our dura mater, arachnoid matter. Then we have our pia mater, which is located in here. And we have our cerebral spinal fluid, which protects the brain and the spine, right? So there are times where people can have certain fractures, okay, which we'll get into in a little bit, but I'll kind of cover now and kind of reiterate a little bit later on. We can have something called a subdural bleed, okay? This is in the dural space located here. So subdural. We can also have something called a subarachnoid bleed. That's a bleed a little bit closer to the brain, all right? So there's different types of bleeds that can happen anytime you get a traumatic injury. Or you can have just a head bleed from a pop vessel as well, which is why it's very important that we're checking patients' blood pressures, because hypertension can be a cause of this as well. CSF, or cerebral spinal fluid, is produced in a chamber inside the brain called the third ventricle. So there's approximately 125 to 150 mLs of cerebral spinal fluid in the brain at any time. And CSF primarily acts as a shock absorber. So if you have that shock to your brain or that traumatic blow, that CSF is supposed to protect it from becoming injured. When an injury does penetrate all the protective layers, a clear watery CSF may leak from the nose, ears, or even an open skull fracture. So we mentioned this before, and I'll ask you guys again. How do we check and see if it's actually cerebral spinal fluid? What do we do?
Take a sample of blood on a gauze, and if it creates a halo.
Exactly. Perfect. All right, so let's go to the spinal nerves. There are 31 pairs of spinal nerves. These spinal nerves conduct impulses from the skin and other organs to the spinal cord. They also conduct motor impulses from the spinal cord to the muscle. And the spinal nerves also serve the extremities. So the extremities are arranged in a complex network, which I'll show you guys in the next slide here really quick. All right. So as you can see, looking at the slide here, we have our spinal cord that runs here. Now, inside our spinal cord, from top to bottom, well, that's a trauma a little bit, or more of the A&P stuff as well, for bones. How many vertebrae do we actually have? How many vertebrae do we have in our spinal column?
Either 72 or 114. I can't remember.
That's a lot. Any other thoughts, guesses?
Is it 37 or 39?
So Tandra's going, Ashley's going with 33. So it's 33 total. Right? How many sections of the spine are there total?
Is it 4, 5?
5. We have 5 sections of the spine that total a 33 vertebrae. Let's break them down. These are good to know because we're going to have to memorize these anyways. How many cervical vertebrae are there?
7,
7.
7. Thoracic.
12,
Yep, 12. All right, what's the next one down? We have cervical, thoracic.
lumbar.
Yep, lumbar. Good job, lumbar. How many are in there?
Is that 5?
5. That is correct. What's the next one? Next one down. Yep, that's correct. Sacral. Andre, you got it right. Sacral. So there are how many vertebrae there? So we
Isn't
have
the
5.
sacral?
Yeah, keep going with that because Tondra just posted the answer too. But keep going. So the sacral is 5 vertebrae, but they are fused together. And then what's the last section?
Your tailbone.
Otherwise known as the coccyx. And how many vertebrae are there?
Is that 5 also?
4. 4. So it should be 7, 12, 5, 5, 4, totaling 33. The only unique parts are the sacral and the coccyx because those are fused together. And that's the difference. All right. So we got all those down the best we can. Because as you're palpating the spine, you have to have an idea where these vertebrae are located. All right. It's going to be a very important part of your assessment finding for anything spinal. So this is kind of covering the different nerves in the systems coming off our central nervous system being here, and then our peripheral nervous system kind of branching off. So the brachial plexus system up here, and the lumbosacral sacral plexus located down here. All right, and obviously our messages are all sent through these nerves, going through from the peripheral system to the central system, up through the brain's, excuse me, up to the brainstem, and then into the brain, where then it can say, oh, this is not good. We probably shouldn't be doing this. Transmits a signal back down through the central to the peripheral, into the plexuses, into the extremities, saying, hey, let's not do that anymore. All right, next, maybe. So there are 12 pairs of cranial nerves. The cranial nerves transmit information directly to or from the brain. Hold on one second. One of you guys just texted me. I'm trying to reply back. All right, so let's back to the cranial nerves. So there are 12 cranial nerves, all right? So let me ask you this. What are they? And please don't say number 1 through number 12. Any thoughts? What are the 12 cranial nerves? Let's start with number 1. So the number 1, the cranial nerve, so the first cranial nerve is called the olfactory nerve. Cranial nerve number 2 is the optic nerve. Number 3 is the ocular motor nerve. Number 4, trochlear nerve. Number 5 is the trigeminal nerve. Number 6 is the abducens nerve. Number 7 is the facial nerve. Number 8 is the vestibulocochlear nerve. Number 9 is the glossopharyngeal nerve. Number 10 is the vagus nerve. Number 11 is the spinal accessory nerve. And number 12 is the hypoglossal nerve. Out of all of those nerves, which one is the most important one that we see quite often and causes a lot of our problems that we run into with patients?
Is it the vagus nerve?
It is the vagus nerve. That is correct. So Deb put down hers as number 7. So why is that vagus nerve so important?
Is that the one that sends a signal to the heart?
It does. So if you bear down, or if everybody, well, let's find out. Why should everybody do this? Because if you bear down like you're trying to poop yourself, all right, what you're doing is you're stimulating your vagus nerve, all right? So why would that be important to know?
They can cause heart attacks.
Yeah, what else can it cause though? Severe what? Bradycardia. So why is this all important for us? We talked about heart attacks. What else can happen? Let's throw pharmacology into this a little bit. What would happen if somebody, let's say an elderly male, we'll say, all right, is on beta blockers? What do beta blockers do? And we cover this in pharmacology. They don't
I'm going to go out
vasodilate.
on a limb and say they block signals.
Like beta receptors.
Yeah, the only reason I know about this is because this is what just recently happened to my grandmother. So the vagus nerve.
That it's something with heart rhythms, right? They block
Okay.
abnormal heart rhythms. I think.
Yes, it can help with the people that are on AFib can take that. But what it's really doing, and I see reducing blood pressure from Tondra. That is correct. It can reduce blood pressure. Let's see. I'm trying to read Deb's here. So complete CV block, so they need so trying to think. Sometimes, Deb, the need for what's happening with a beta blocker is it's dropping your heart rate. Okay, it also reduces blood pressure. Something to think about though, okay? So you got somebody, an elderly person who has a hard time recovering from certain things, and they're on a beta blocker, which already drops their heart rate, and now they're constipated, and they try going to the bathroom, and then they bear down to push, trying to make that hard poop come out. What happens next? You already have your heart rate controlled, and it's already low as it is from the medicine.
Could they have a stroke? Could they have some sort of aneurysm?
They'll probably code.
Yeah, they code out. They stops blood flow to the heart.
Right, because your heart rate is dropped so low that your heart is no longer pumping effectively. I'm talking heart rates drop down into the 10s and 20s because they're trying to push out that constipated hard poop. At the same time, they're on beta blockers. They stimulate their vagus nerve, causing a vasovagal syncope, which Tondra just mentioned syncope on here, all right, to the point where they don't recuperate and then they code. So this is when you hear the term commode code comes into play. It's when the elderly sit on the toilet and poop and they die. Usually it's from a vasovagal syncope that they can't recover from. Ah, Elvis. Yeah.
Elvis too, right? Yeah, right.
Yeah. So kind of bringing all this stuff to light, everything we talk about here all plays into something else. That's why it's so important to understand pharmacology, anatomy, and physiology, and putting all this stuff together with the nervous system. It can definitely have different effects to it. All right. Are things starting to come together better now that I mentioned that?
Yeah, the other place I've seen it happen, especially with my grandmother, is because she has to be bathed, and a lot of times it's the pressure of her going down or up in a tub, and it happens also because she's pressing or pushing.
Yep. So how many of you guys in the class have kneeled down or squatted down like in a catcher's stance and stood up really fast and go, whoa, oh, a little dizzy for a minute there? Has that happened to you guys before?
Definitely.
Sean? Yeah. Okay. And Joy says many times. It's because you are stimulating your vagus nerve, causing your heart rate to drop and everything else. So you're down low. When you stand up fast, you have a vagus nerve stimulation. This is why it's so important to understand the cranial nerves on a stroke assessment. But on top of that, understand the 10th cranial nerve, the vagus nerve, is one of the most important nerves in the body because that controls stimulation. Now, I'm not saying to go ahead and try this because if you pass out during class, unfortunately, we cannot help you. we're kind of far away. So don't do that. So these transmit information directly to or from the brain and perform special functions in the head, face, including sight, smell, taste, hearing, and facial expressions. That's why it's so important to understand these cranial nerves. There are two types of peripheral nerves. There's sensory, which carry only one type of information from the body to the brain via the spinal cord. And there's motor nerves, and there's one for each muscle, which carry information from the central nervous system to the muscle itself. Then we have connecting nerves. So the connecting nerves are found only in the brain and the spinal cord. And what happens is they connect the sensory and motor nerves with short fibers, allowing for exchange of simple messages. So the nervous system controls virtually all the body's activities, including reflex activities, voluntary activities, and involuntary activities. Let's go more into that here. So the connecting nerves in the spinal cord form a reflex arc, which I'll show you guys in the next system, or slide, as you say. So the sensory nerve in this arc detects an irritating stimulus, It bypasses the brain and sends the message directly to a motor nerve, causing a response. So as you can see here. Now, there are patients that receive neuromuscular blockers, and there's medications that are out there that can actually stop nerve ending pain. And I'm drawing a blank of the name of the medication that the hospital can give, but it works phenomenal for pain if people have a nerve ending or type of pain like that. I'm drawing a blank of the name of what it's called. But as you can see here, though, this guy's putting his hand over a candle. It transmits in here and spins right back around. So the sensory nerve kicks in. The connecting nerve cells are here. It spins right back to the motor nerve and says, pull your hand away. All right. So when we start doing a neurological assessment on these patients, gabapentin, thank you, Deb. We start doing assessments. This is why we actually check for sharp and dull sensation to make sure that their sensory and motor nerves are working appropriately. If I take a sharp object and I push it against your hand and you can't feel it, right, then I'm just more suspicious of a spinal cord injury, right, or some kind of something neurologically is blocked somewhere, right? That's why it's so important to make sure you do the sharp and dull test. So they should be able to tell the difference based on sensory, and you're checking sensory nerves by doing so. All right, so voluntary activities are activities that we consciously perform, in which sensory inputs determine the specific muscular activity. Involuntary activities are actions that are not under conscious control, such as breathing. The somatic nervous system, or the voluntary nervous system, handles voluntary activities. So the brain interprets the sensory information that is received or receives from the peripheral and cranial nerves and responds by sending signals to the voluntary muscles. Excuse me. The autonomic involuntary nervous system handles the body functions that occur without conscious effort. So this will controls the functions of many of the body's vital organs. It divides into two sections called the sympathetic and parasympathetic system. So when confronted with a life-threatening situation, the sympathetic nervous system reacts to the stress with a fight or flight response. This response causes the pupils to dilate, smooth muscles in the lungs to dilate, heart rate to increase, and blood pressure to rise. So during this time of stress, a hormone called epinephrine or adrenaline is released. Right? So adrenaline, epinephrine, or norepinephrine is another name as well. This is called a neurotransmitter. So the neurotransmitter for the sympathetic nervous system is norepinephrine or epinephrine, adrenaline. Right? The parasympathetic nervous system has the opposite effect of the body, causing blood vessels to dilate, slowing the heart rate down, and relaxing the muscle sphincters. So as the body attempts to maintain homeostasis, these two divisions of the autonomic nervous system tend to balance each other out so that the basic bodily functions can remain stable and effective. The neurotransmitter for the parasympathetic nervous system is called acetylcholine. So why is the parasympathetic and sympathetic nervous system important to us? What do you guys think?
It supports the unconscious reactions to various stimuli.
Okay. Now, let me throw pharmacology at you now. We're going to try putting a lot of this stuff together. This is why it's so important. Do we have any medications at the EMT level that can stimulate these systems or mimic these systems?
Epinephrine.
Epinephrine. What else? What's another medication
Maybe
administer?
nitro.
Nitro is a
Listen.
vasodilator.
Vasodilator.
Yep. It's a nitrate vasodilator. Let me ask you guys this question then. Has everybody done the CPAP video yet?
Ooh, oxygen.
No, not oxygen.
Duo
But has
nebs.
everybody? There you go. So you mentioned duo nebs. What part of the duo neb? Remember, duo nebs are duo, 2 parts, right? 2 different medications together. Which one of the 2 would stimulate the sympathetic nervous system?
Albuterol.
Albuterol. I'm gonna go back to the chat box in a second, because I know you guys are putting stuff down in there, right? So albuterol is what they call a sympathomimetic. Okay, sympathomimetic, because it mimics the sympathetic nervous system, causing that increased heart rate and everything else that we talked about. So this goes into receptors. Okay, this is why it's so important to understand anatomy and physiology when you're giving medications. If you have a patient who's receiving albuterol or a duoneb, we give them that sympathomimetic medication, we're stimulating 2 receptors. The first one is a beta 1 receptor, and we also stimulate the beta 2 receptor. The way to remember this, beta 1, think of 1 as 1 heart. So therefore, a beta 1 affects the heart. Beta 2, you have 2 lungs, affects the lungs. So albuterol is a beta 1, beta 2 sympathomimetic. And the reason why I say now beta, so beta 1 heart, is rate. Beta is rate. If I said alpha 1, that's vasculature, okay? Dilation, constriction of the vasculature itself. So albuterol, a medication that an EMT can administer through a CPAP, has beta 1, beta 2 effects, okay? So beta 1, you're going to have an increased heart rate, expect to see tachycardia, it's part of it. And beta 2 is that bronchodilation of the lungs. We are having a sympathetic nervous system stimulant to the system. All right? Does that make sense?
It's like we're assisting that nervous system to react so we can help them.
Yes, for the lungs. We're trying to make it react to cause that bronchodilation. And we're also, in turn, though, we have to increase that heart rate. If we increase the heart rate, what happens to oxygen demand?
That increases.
Right, goes up. Everything we do has a cause and an effect, whether it be assessment, a treatment, a medication. There's a cause and an effect of what we do. And a good EMT, a very good EMT, understands cause and effect. If we do something, something is going to change, whether it be better or worse, hopefully for the better. If we give someone albuterol, we expect to see a sympathetic nervous system change. Now, patients that are on beta blockers that slow the heart rate down, right, can make that change not happen. So you got to look at their medication list and look at what you're giving them for meds. You're still going to get that bronchodilation, but you may not see that tachycardia. All right. Now, I'm going back a little bit here. Jeff, you mentioned aspirin, okay? Aspirin is a platelet aggregator or an antipyretic medication. So a platelet aggregator means that it makes the platelets in the system less sticky, right? So if you think of Spider-Man, how Spider-Man he grips on to stuff and he doesn't let it go, right? Well, if that clot is coming through, it makes Spider-Man lose his ability to hold on to anything. All right, that's a good way to remember it. It makes it less sticky, so platelets cannot no longer clot, making that clot worse in the heart. It makes things less sticky, so things just smooth right by. It's not a blood thinner, though. That's the difference. And then, Deb, opioids, those are different. Those are narcotics. And we expect to see things slow down, like slower than the heart rate down. It's like morphine, hydromorphone, fentanyl, and things like that we'd be seeing in the field for the opioids. Right? So we're not going to see that tachycardia. However, I'm glad you brought that up as well, because if you give somebody Narcan and they come out of their high, they can become very tachycardic. You just got to keep an eye at that. All right. I didn't mean to go too much in detail on this, but I thought you guys should have put things together at this point. Medications mean a lot. And if we're giving meds, you guys need to understand. I know this is a head and spinal injury, but I wanted to kind of toss that kind of stuff into the nervous system itself. Hopefully I didn't go too in depth with you guys. All right. So the skull is composed of two groups of bones, right? The cranium, which is a thick shell above the eyes and the ears that protect the brain, and then the facial bones, right? So looking at the face, the mandible starting low to high, mandible, maxilla, the zygoma, or what they used to call the zygomatic bone, the nasal bone, and then the cranium. The cranium is composed of 80% brain tissue, 10% blood supply, and 10% cerebrospinal fluid. You'll probably see these numbers on a test again, so take notes. There are four major bones that make up the cranium. There's the occiput, the temples, the parietal regions, and the frontal region. Four bones in the brain, or in the head. The face is composed of 14 bones, right? The maxillae, the zygomas, the mandible, and the orbits. What is the nose mostly made of?
Isn't it
Cartilage.
cartilage?
Cartilage. Yep, flexible cartilage. But you can still have a nasal fracture. So the spinal column. We talked about the vertebrae already, divided into 5 sections. So I'm not going to hit this too hard. We've already kind of covered this. 33 into 5 sections. Cervical, thoracic, lumbar, sacral, coccyx. All right. So injury to the vertebrae can result in paralysis, right? Whether it be swelling, part of your spinal processes pushing up against it, to severance. It can cause either temporary or permanent paralysis. The front part of the vertebrae consists of a round, solid block of bone called the vertebral body. The back part forms a bony arch. The series of arches form a tunnel called the spinal canal, which encases and protects the spinal cord. All right. The vertebrae are connected by ligaments and separated by cushions called intervertebral discs. The older you get, a lot of times that cushion starts to go away. That's when you start having significant back pain as well. It can also cause this. The spinal column is almost entirely surrounded by muscles. Now, as you're palpating the spine, what you're looking for going from top to bottom, okay, and literally you go right down to the person's butt crack, right, top of the head, the top of the neck to the butt crack, all the way down. We're going to feel the bony points that you feel are called spinal processes or processes. What we're feeling for is to see if everything should be in line, and we're feeling for something called the step off, right? So if you're feeling down and one steps off to the side, there potentially could be a spinal issue that's there, all right? All right, so head injuries. Traumatic insult to the head that may result in injuries to soft tissue, bony structures, or the brain. Approximately 4 million people experience head injuries of varying severity in the United States each year. 4 million people. All right. 52,000 deaths occur annually as a result of severe head injury. 52,000 people die from this. Head injuries account for more than half of all traumatic deaths. All right. So fatal injuries invariably involve the brain. So you want to make sure you be alert to the fact that the patient may have sustained additional trauma such as cervical spine, pelvic, and chest injuries as well. All right. So you got to just keep that kind of stuff in mind. All right. We're going to finish up head injuries. It'll take 5 minutes. We'll be at this for an hour. There's two types of head injuries we're going to run into. There are only two types: closed head injury and open head injury. Closed head injuries are those in which the brain has been injured, but there is no opening to the brain. These are dangerous because we can't see what's going on underneath. An open injury is one where the opening from the brain to the outside world exists, so we can actually see inside the brain. Now, both very dangerous, okay? You just got to keep an eye on those. Obvious skull deformity with a break in the skull is a sign of an open head injury, which is often caused by a penetrating trauma. So there may be bleeding and exposed brain tissue. Head injuries bleed very badly, whether it be a small laceration to a major laceration or a fracture of some sort. It's very dangerous very bloody, because it's so vascular on the top. And things like this can happen. All right, number 3. So motor vehicle crashes are the most common mechanism of injury with this, where more than 2/3 of the people involved in a motor vehicle crash experience some type of head trauma.
How's it going? Yeah. Good practice? Yeah.
Right.
Yeah.
So,
Yeah.
injuries
Hey guys.
also occur in victims of assault, when
How
elderly
was it?
people fall.
Can you bring this in?
Yeah.
And this.
Right. Hold on. I'm listening to my class right now.
Hey, Nick, you're unmuted.
I'm gonna go.
So during sport-related injuries, or in a variety of incidents involving children, or any head injury that's potentially serious, if not properly treated, you want to keep close eye on the elderly, all right? And why is that? Why do you want to keep close eye on the elderly when they fall? What are some questions you want to ask the elderly when they do fall? Yeah, they can deteriorate pretty rapidly. What other
You want to
question
ask
do we
them
want to
if they're on blood thinners?
Blood thinners. Good. Medications. Are you on blood thinners? And I know we've talked about this before. If you respond, let's say, to a fall and you transfer them to the hospital, they're going to do a head CT. It comes back clean. Okay. And a week later, you respond back to that same nursing home or home, and they say, I'm not sure why he's unresponsive, but he's unresponsive in bed. We're not sure what's going on. All right, did he have any recent falls? Well, yeah, he fell a week ago. Is he on blood thinners? Yeah, he's on blood thinners. All right, let's get him to the hospital. He most likely has a head bleed, right? So you want to keep that kind of stuff in mind with the head trauma, is because they may have such a small bleed that even a CT won't pick up right away, but over time, because it can't clot on its own, it builds up and builds up to the point where they go unconscious. So you want to keep that kind of stuff in mind, all right? Perfect. And I cannot see this, but these are general signs and symptoms of a head injury, and it is very tiny on my screen, so you guys take a look at this. Why don't we come back in 5 minutes, and we'll continue on. Go ahead and take 5.
This conference will now be recorded.
All right, so let's talk about scalp lacerations. So we kind of touched on this a little bit about 10 minutes ago or so, which can be minor or serious. But even a small laceration can lead to significant blood loss and could be severe enough to cause hypovolemic shock, right? They're often indicators of a deeper, more serious injuries, right? So occasionally this can happen. Our heads, our scalps are very, very vascular and can cause significant blood loss if there were to be any kind of laceration or injury. All right. So significant force, as far as skull fractures go, significant force applied to the head may cause a skull fracture. And the fracture can either be open or closed depending on whether there is a overlying laceration of the skull. So when we do our assessments, we want to make sure that we're palpating the cranium, but we're trying to feel for any kind of like a mushy type spot or any kind of indentation that could be indicative of a fracture. So injuries also from bullets or other penetrating weapons frequently result in a fracture of the skull as well. So some signs of skull fractures include, and I'll show you guys some pictures next of raccoon eyes and battle signs as well. The patient's head appears to be deformed, visible cracks in the skull, ecchymosis that develops under the eyes, which we call raccoon eyes. These are more of your occipital orbital fractures, or ecchymosis that develops behind one ear over the mastoid process, which is called a battle sign, right? So battle signs would be more indicative of a basilar skull fracture. If you see a basilar skull fracture or battle signs like that, what device that we have that we can utilize for airway management is contraindicated. No, not CPAP. So if you see that battle sign behind the ear like that, what other airway devices can we utilize that is considered contraindicated for battle signs or a basilar skull fracture? What airway adjunct am I talking about? All right, type this one here for you. NPA. Yep, Taylor, good job. Nasopharyngeal airway, contraindicated. Very good. All right, so linear skull fractures, as you can see in the picture here, is known as a non-displaced skull fracture, account for approximately 80% of all fractures to the skull. Radiographs are required to diagnose a linear skull fracture because they are often no physical signs such as deformity. If the brain is uninjured, then there are no scalp lacerations, then a linear skull fracture is not life-threatening. The biggest thing they need to do is do a CT to make sure there's any kind of bleed underneath the skin, underneath the skull. A depressed skull fracture, as you can see in the picture here, is a result from a high-energy direct trauma to the head with a blunt object. The frontal and parietal bones of the skull are most susceptible to these, and bony fragments may be driven into the brain, resulting in injury. I've had quite a few patients with this, and I do have an X-ray of a 9-year-old skiing accident that I went to, with permission from the family to use it in my classes. So I have a picture of the X-ray, and it's a depressed skull fracture. Just very close to temporal frontal lobe impact. Patients often present with a neurological signs such as loss of consciousness. What was that? A basilar skull fracture associated with a high energy trauma, but usually occur following diffuse impact of the head, like falls, motor vehicle crashes, things like that. These injuries generally result from an extension of a linear fracture to the base of the skull and can be difficult to diagnose without radiology. Signs of a basal skull fracture include CSF drainage from the ears, raccoon eyes, and battle signs. As you can see in the photo, if you have a fracture here, we'll see battle signs, the drainage, and raccoon eyes as well. Also, with this as well as orbital fractures will also cause raccoon eyes as well with it. Open skull fractures result when a severe forces are applied to the head and are often associated with trauma to multiple body systems. Brain tissue may be exposed to the environment, which significantly increases the risk of bacterial infection as well. And they have a very high mortality rate. All right. All right. So traumatic brain injuries. So the National Head Injury Foundation defines TBI as a traumatic insult to the brain capable of producing physical, intellectual, emotional, social, or vocational changes. The most serious of all head injuries. They're classified into two broad categories: primary direct injury and a secondary, which is indirect injury. The primary brain injury results instantaneously from impact to the head, where a secondary brain injury increases the severity of the primary injury and may be caused just had a moment. So it may be caused by increased swelling of the brain and things like that as well. So what they're saying here is instantaneous impact causing significant head trauma, or if they have a slight head trauma, let's say like a bleed or some sort, or swelling, that they can't reduce over time, a secondary injury, brain injury occurs because of that increased severity of the primary injury over a certain period of time versus instantaneous as well. Okay. So secondary injuries also may be caused by hypoxia, hypotension, cerebral edema, intracranial hemorrhage, increased intracranial pressure, cerebral ischemia, and infection. Hypoxia and hypotension are the two most common causes of secondary brain injury and will cause increased death and disability significant in a patient with a head injury. Secondary brain injury may also occur a few minutes to several days following an initial head injury. So let me ask you guys this. How can you tell a patient has increased intracranial pressure? What do you guys think? How can you tell somebody has increased intracranial pressure? Can you guys hear me okay? I see Cushing's. Nope. Counting fingers. Skin color. All right, so now I'm going to ask you guys, I'll give you this here. What is Cushing's triad? Cushing's triad, what is it? Feel free to speak.
Bradycardia, irregular respiration, and hypertension.
Yep. So those three indicators would indicate someone has increased intracranial pressure. All three things that can be diagnosed and seen by an EMT. All right. Let's go to the next slide. I hit the right button. All right. So the brain can be injured directly by a penetrating object, such as a bullet, knife, or other sharp object, or indirectly as a result of external forces exerted onto the skull. So remember we talked about counter-coup injury, right? Which will result from striking a windshield. So remember, our brain is kind of like something that sits in water, right? CSF. That's our protection, right? And our brain is like a walnut inside of a water bottle. So we can actually have a counter-coup injury because our brain bounces back and forth, causing multiple contusions in the brain. So the passenger's head hits the windshield. The brain continues to move forward until it comes to an abrupt stop by striking the skull. Then the head falls back against the headrest or a seat, and the brain slams in the rear of the skull. This can cause contusions and cerebral edema, swelling of the brain, which may not develop until several hours later following the initial injury. Low blood oxygen levels aggravate cerebral edema and can minimized by maintaining high oxygen saturations. It is not uncommon for the patient with a head injury to have a convulsion or a seizure. Okay, because now we have significant trauma to the brain bouncing back and forth. We start getting oxygen depletion, then we start having seizures. All right. So these are all things you got to pay attention to. That's why it's always important to pay very close attention to anybody with a head trauma, because it can actually cause a seizure. Intracranial pressure, which is accumulations of the blood within the skull or swelling of the brain, it can rapidly lead to increased intracranial pressure, ICP. ICP then squeezes the brain against the bony prominences with the cranium. We don't want this to happen. So Cushing's reflex or Cushing's triad. You'll also see Cheyne-Stokes respirations or ataxic respiration, or what they call biot respirations. Decreased pulse rate, headache, nausea, vomiting, decreased alertness, bradycardia, sluggishness, or non-reactive pupils. Decerebate posturing, decordicate posturing, increase or widen blood pressures, or Cushing's triad, which we just talked about. So bradycardia, irregular respirations, hypertension. And mostly it increased systolic blood pressure, not so much diastolic. Kind of add to that. Intracranial hemorrhage, bleeding inside the skull also increases intracranial pressure, and bleeding with this can occur between the skull and the dura mater, beneath the dura mater, or outside of the brain, or within the tissue of the brain itself. We start talking about these different hematomas. I'm going to show you guys these here next. So an epidural hematoma, as you can see in the photo to the left-hand side, is an accumulation of blood between the skull and the dura mater. This is nearly always the result of a blow to the head that produces a linear fracture of the thin temporal bone. Arterial bleeding into the epidural space will result in rapidly progressing symptoms. Often the patient will lose consciousness and immediately following the injury. And also with this as well is often followed by a brief period of consciousness or a lucid interval, after which the patient lapses back into unconsciousness again. Death will follow very rapidly without surgery to evacuate the hematoma. Wrong button. A subdural hematoma is accumulation beneath the dura mater but outside the brain still. Usually occurs after falls or injuries involving a strong deceleration force. More common with an epidural hematoma, more common than an epidural hematoma, and may or may not be associated with a skull fracture. A subdural hematoma is associated with venous bleeding, so the signs typically develop more gradual than an epidural hematoma. The patient may also often experience fluctuating levels of consciousness or slurred speech, and a patient with a suspected subdural needs to be evaluated by a physician. All right. So as we know, the epidurals are more serious than a subdural hematoma. Intracerebral hemorrhage or hematoma involves bleeding within the brain tissue itself. Right? This can occur following a penetrating injury to the head or because of rapid deceleration forces. So many small, deep intracerebral hemorrhages are associated with other brain injuries. So intracerebral hemorrhage hematomas may also have a high mortality rate, even if the hematoma is surgically evacuated. We're causing a lot of tissue death with that. A subarachnoid hemorrhage is bleeding that occurs in the subarachnoid space where CSF circulates, resulting in bloody CSF and signs of meningeal irritation. Common cause include trauma or rupture of an aneurysm. The patient reports a sudden severe headache, a sudden severe A sudden, severe, or subarachnoid usually results in death, and survivors have often have prominent neurological impairment. So if you have patients that tell you they have the worst headache they've ever felt in their life, I feel like I'm going to die, it's so bad, and they say it's in one specific spot, it's most likely going to be a head wound. These patients need to be transported rapidly. If they say they have chest pain, withhold nitro. The last thing you want to do is take a bleeding head and vasodilate it more. All right? So we withhold nitro, we withhold aspirin, get them to a hospital. These patients need to have a CT done right away to make sure it's not a head bleed. A concussion is a blow to the head or face that causes a concussion of the brain. Concussions are also known as mild TBIs. So in general, it's a closed head injury with a temporary loss of alteration of part or all the brain's abilities to function without demonstrable physical damage to the brain. Approximately 90% of patients do not experience a loss of consciousness. Concussions have become very, very, I'm not going to say popular, but a very high rate of discussion, especially now in the sports field. And have you guys seen the movie Concussion with Will Smith in it before? It was based off a true story. You guys seen that? All right. If you ever get a chance to watch it, for those of you who have seen it, you can comment on it as well. They found that patients were developing what they call CTE, which is chronic traumatic encephalopathy. So CTE stands for. So it's repetitive blows to the head. And they were seeing this in boxers, but the NFL was saying, no, there's really nothing going on with it and things like that. And this doctor found it and said, oh my God, this is what's actually going on. And CTE is a release of what they call a tau protein. Yep, probably like Aaron Hernandez. Yep. So the thing is that it's releasing a bunch of tau protein, causing significant blows to the brain and bleeds and everything else, to the point where they were healing, they were seeing what appeared to be early Alzheimer's, but patients in their 50s should not be getting Alzheimer's. Not at 50 years old. It's very rare that ever happens in their 40s and 50s. So they did and there's no way to diagnose this until the patient's actually dead and they can do a cross-reference of the brain and actually find this. And they were finding that every NFL player that was dying or committing suicide or things like that, when they were cutting them open, they were noticing this. And it's a great movie to watch, especially for TBI and head trauma. I thought Will Smith did a great job in that movie with it. And yes, Dev, I remember when they found that for real as well, when they started going through that. And the NFL pretty much said, no, that's not true at all. So now in high school, if you get a concussion, you're pretty much out for the entire season. They take things very seriously now. And coaches go through special training now to pick up on concussions and actually see the signs and symptoms. All right. So a patient with a concussion may also be confused or have amnesia, which means that he or she cannot remember everything but events leading up to the injury itself. These are the patients you want to ask this question to as part of your assessment. Can you remember these 4 items? And give them 4 items to remember, whether it be purple, black, yellow, pink, it doesn't matter what it is. Pick 4 items, make sure you write them down yourself so you don't forget what they are, and see if they can remember what they are in 5 minutes from now. Another thing you also want to keep in mind with head injuries as well is repeated questioning. Why am I in the ambulance? And you tell them why. Where am I going? You're going to the hospital. 5 minutes later. Where are we going? We're going to the hospital. We just told you this. You don't remember me telling you? No. All right. Signs of a head trauma. Signs of a head injury. right? You want to make sure you're asking all these questions. Other symptoms would be dizziness, weakness, visual changes, nausea, vomiting, ringing in the ears, slurred speech, and the inability to focus, right? You can also get profuse sweating and things like that as well, diaphoresis. These are all things you just need to be able to pick up on as you go through your assessment. And the thing is, they can have concussion symptoms even a week later. Lack of coordination, delay of motor functions, inappropriate emotional responses, temporary headaches, and disorientation. We should always assume that a patient with the signs and symptoms of concussion has more serious injury until proven otherwise. All patients with signs and symptoms of a concussion should be evaluated by a physician. They need to get a CT done to make sure they don't have a bleed. Contusions are far more serious than a concussion. Like any other soft tissue in the body, the brain can sustain a contusion, a bruise, or the skull is struck. A contusion is far worse and involves physical injury to the brain tissue, which may produce a long-lasting and even permanent damage. So a patient who has suffered a brain contusion may exhibit all the signs, any or all the signs of a brain injury. So keep this up in mind when you're doing your assessment. Other brain injuries can also arise from medical conditions such as blood clots or hemorrhages. So problems with the blood vessels could be high blood pressure, or other problems may be caused by spontaneous bleeding in the brain, affecting the person's level of consciousness, the patient. This is known as altered mental status. So signs and symptoms of non-traumatic injuries are often the same as those of TBIs, except there are no obvious history of MOI or other external evidences of trauma. So you still want to make sure you're doing your full stroke assessment, Cincinnati stroke scale, right? FAST-ED scale. What is the Cincinnati stroke scale? What are the 3 things we have to do to measure that?
Is it
You guys still
speed,
there?
arm drift?
Yep.
Man, I can't remember the third one.
Right, you got speech and arm drift. Anybody else want to help them out?
That pupil reaction?
No, that's one thing you want to look for, but that's not the third thing for it, though.
Okay.
You definitely want to look for pupil reaction to see if they're unequal or not. Right, and Deb said speech. That's the other one. Slurred speech, facial droop, and then pronator drift, they call it. Awesome. Good teamwork. All right, so spinal injuries. So spinal injuries, so we look at the cervical, thoracic, and lumbar portions of the spine can be injured in a variety of different ways. We have compression injuries that result from a fall, regardless of whether the patient landed on his or her feet or experienced a direct blow to the crown of the skull, coccyx, or top of the head. Forces that compress the patient's vertebral body can cause herniations of discs. Subsequent compression on the spinal cord and the nerve roots and fragmentation into the spinal canal. Motor vehicle crashes and other types of trauma can overextend or hyperflex the cervical spine and damage the ligaments and joints. Rotational flexion injuries of the spine result in rapid acceleration forces, more likely to happen at C1 and C2 over your atlas and axis. Injuries are to the area of the spine are considered unstable due to the location and the lack of bony and soft tissue support. All right. So any of these unnatural motions, as well as the excessive lateral bending, can result in a fracture or neurological deficit. So when the patient is pulled along its length, like a hyperextension, it can cause fractures of the spine as well as ligaments and muscle injuries as well. So when the bone, excuse me, when the bone of the spine are altered from traumatic forces, they can fracture or move out of place. That's the whole step off thing that I was talking about by feeling the spine from top to bottom. You want to feel for those step offs. When injuries pinch, pull, or penetrate the spinal cord, permanent damage may occur with this. So some common findings includes pain and tenderness on palpation, and you want to palpate every vertebra going down, okay? You're not going to be able to palpate C1 and C2. Those are kind of too far up the neck, all right? You'll be able to palpate from C3 to C7 and all your thoracic vertebra going down to your lumbar, sacral, and coccyx. You'll be able to palpate all the way down. Common findings include pain and tenderness on palpation. So you may feel or observe a deformity of the spine. Talk about, again, step-offs, where the spinous process may be palpable. If you suspect these types of injuries, take extra precautions in stabilizing the spine. We don't want them to have them twist, turn, and move, because that can cause more significant damage. As far as patient assessment goes, always suspect a possible head injury or spinal injury anytime you encounter one of the following mechanisms of injury. Motor vehicle collision, including motorcycles, snowmobiles, and all-terrain vehicles. Pedestrian motor vehicle collision. Falls greater than 20 feet for an adult and 10 feet for pediatrics. You're going to see those numbers again, so I'll say it again. Falls greater than 20 feet for adult, greater than 10 feet for a pediatric. Blunt trauma, penetrating trauma to the head, neck, or back or torso. Rapid deceleration injuries, hangings, axial loading injuries, injuries where the load is applied along the vertical to longitudinal axis of the spine, so falling from a height and landing on the feet in an upright position. Then diving accidents. So as part of our assessment goes, we're going to do our scene size up, which we talked about many times before, making sure your PPE is on correctly. We're going to look at the mechanism of injury and how it actually happened. Consider how the MOI produced the injuries expected. We're going to focus on identifying and managing life-threatening concerns. We're going to treat life threats, the circulation, airway, or breathing, and then consider life-threatening until treated and must be treated immediately. Life-threatening external hemorrhage must be addressed again. Most head injuries are considered mild and result in no or limited permanent disability. So a number of patients with head and spine injuries also will not require much intervention other than a thorough assessment and continued observation during your transport. All right. In patients who have problems with ABCs or other conditions, for you to decide a rapid transport to the closest appropriate hospital is needed. Rapid immobilization of the spine and neck and a quick loading into the ambulance may be indicated. So reduction of on-scene time and recognition of a critical patient increases the patient's chance for survival or a reduction in the amount of irreversible damage. So do your assessment. Look at these patients. Get them trauma naked in the back of the ambulance, right? Palpate everything. Spine, abdomen, chest. I mean, do your full assessment, right? Pick up on the criticals and take care of the critical issues that are at hand, and then move forward, right? We no longer backboard patients. Our backboard is now our stretcher, but we have to do it the appropriate way, which we'll discuss more during our practical sessions on how to immobilize patients appropriately. Spinal mobilization considerations. So when assessing the patient, be aware that any unnecessary movement of the patient can cause additional injury. So you want to assess the patient in the position found, determine whether or not a cervical collar needs to be applied. Even if they pass spinal rule out, if the mechanism is there, put a cervical collar on, protect yourself, right? Begin by assessing the scene, determine the risk of injury. Before get your general impression, are they sick or not sick, based on the level of consciousness and the chief complaint. If the patient is absolutely clear, his or her thinking, and doesn't have any neurological deficits, spinal pain or tenderness, evidence of intoxication, or other illnesses or injuries that may mask a spinal injury, you may consider not placing a patient in spinal restriction. Many jurisdictions allow EMTs to screen patients. Maine and New Hampshire do allow EMTs to do a spinal screening and use the determination of not putting on a cervical collar. Just keep this stuff in mind that if you choose not to and you miss something, it can fall back on you as a provider. So make sure that you are sure that everything checks out before you decide not to put a C collar on. The backboard often places the patient in anatomically incorrect position for a long period of time. Right? Circulation appears in areas of the skin may become compromised, leading to complaints of pain, ischemia to the skin, and if left long enough, necrosis. Right? This is why we don't use backboards anymore. Some patients could experience respiratory compromise while laying flat. If they have a cervical injury or suspect the spot, they can still sit up. Just put them in a semi-Fowler position. That's perfectly fine. So we try to minimize the amount of time patients on a backboard. So when I first started EMS, scoop stretchers were a big thing. And then they kind of got put on the ambulance and kind of put by the wayside. And everybody's like, use a backboard, use a backboard. Now backboards are no longer being used. Now we're using scoop stretchers all over again. It's amazing how things just go round and round in circles.
We had that conversation today about you can tell how old a person is in EMS by them going to a backboard first.
Yep. Because now we're training everybody to use scoops. If they got their EMT license in the 90s, they were using scoops to get patients off the floor. In the 2000s, they were at backboards. And then obviously 2010 and beyond, I want to say it was about 2014 or 15 when they started getting away from the backboard use. Again. But you can definitely tell how old somebody is in EMS depending on what they're grabbing on the ambulance. So, Dave, if they ask for sandbags, they're really old. More than 20 years. Because Maine used to carry sandbags on the ambulance to treat rib fractures when I first got my license. They finally realized that was a bad thing.
I work with an EMT where her number starts with 0.
Ask her if she
I'm
used to
sorry,
use Matt.
a paramedic where her number starts with 0.
Yep, ask her about mass trousers. She'll tell you all about those. They'll be back. They'll come back at some point. All right, so cervical collars help maintain spinal motion restriction. All right, I will go over how to apply cervical collars on our next in-person class. Right, the best time to apply the collar depends on the patient's injury. Right, if you're doing a rapid trauma assessment, after you assess the neck and spine, throw a collar on and move on from there. Once the cervical collar is on, do not remove it unless it causes a problem maintaining the airway. If you put on a cervical collar and you take it off and the patient moves their neck and they sever their spinal cord, and become paralyzed, that is back on you. When you apply it, leave it on. Do not take it off unless it impedes airway management. We're going to assess for signs and symptoms of a head injury and spine. We're going to begin by asking a responsive patient the following questions. What happened? Where does it hurt? Does your neck or back hurt? Can you move your hands and feet? We're checking, remember, CSMs. Did you hit your head? Right? Also ask him, are you on blood thinners? Confused or slurred speech, repetitive questioning, amnesia, and response to patients are good indications there's a head injury. Right? So in the setting of trauma, assume that your patient has a head injury until your assessment proves otherwise. Decreased blood glucose levels can mimic these symptoms. So you want to make sure you check a sugar. If the patient is found unresponsive, emergency responders, family members, or bystanders may have helpful information. Ask them. Unresponsive trauma patients should be assumed to have a spinal injury. So put them on a collar, get them onto a scoop stretcher or board, get them onto the stretcher, take that stuff off, collar stays on, and get the patient to the hospital. Patients with a decreased level of responsiveness utilizing the APU scale should be considered to have a spinal injury based on their chief complaint. ABC's considerations when a spinal injury is suspected. How can you open and assess the airway? We're going to use what they call a jaw thrust maneuver, which I showed you guys during your airway management on their last practical day, and we'll show you guys again as well. Vomiting may occur in the patient with a head injury, so be ready to turn your patient, right? They're no longer on a backboard and head blocks and everything else. They're sitting on your stretcher, so they turn. You may have to hold C-spine as they turn so they can't bend their neck and possibly have a significant neck injury, spinal cord injury. So pay attention. Irregular breathing may also be a result of increased intracranial pressure. So you want to look for that Cushing's reflex or Cushing's triad. An oropharyngeal or nasopharyngeal airway may assist in maintaining this airway being open. If vomiting does occur, you want to make sure that you are utilizing suction. So have your suction ready. Irregular breathing patterns, such as chain-Stokes respirations, may result from intracranial pressure. Pre-hospital administration of high-flow oxygen is indicated for patients with head and spinal injuries. The pulse oximeter value should not fall below 90%, and ideally should be above 95 or higher. Hyperventilation or ventilating too fast or with too much force should be reduced. So again, if you are ventilating, enough to see chest rise only, right? You should reserve for the specific conditions and perform under certain guidelines as well. Excuse me. This can increase the severity of head injuries if you overventilate somebody. You do not want to hyperoxygenate these patients. Should be avoided except in cases where signs of herniation have been identified. All right, so you got to look for signs of herniation, which we talked about already. Assess the airway breathing prior to moving the patient. Prior to moving on to assessment of the circulation. So a pulse that is too slow in the setting of a head injury can indicate a serious condition, intracranial pressure. If the pulse is present and adequate, you can continue to evaluate your patient further, right? A single episode of hypoperfusion in a patient with a head injury can lead to significant brain damage, even death. We need to make sure we're oxygenating the cells. High flow O2, non-rebreather, 15 liters per minute, let it flow. Assess for signs and symptoms of shock and treat accordingly. If there's bleeding, control it. As far as the manner for transport, patients with impaired airways, open head wounds, abnormal vital signs may need to be rapidly extricated or extracted from a motor vehicle and be transported. You as an EMS provider need to look at your ABCs and do your rapid assessment and make a determination. Is this going to be a rapid extrication, or do we have time to get this patient out? Provide the patient with a patent airway, and supplemental oxygen is paramount. Suction should be readily available, so please do not leave it in your truck if you think they're going to vomit, and maintain immobilization of the C-spine. When you're transporting these patients as well, the use of lights and sirens may increase the patient's level of distress, increase anxiety, which means increased heart rate, and increased blood pressure. These are all bad things, okay? So use lights and sirens sparingly and save them for that true emergency. As far as history taking goes, again, investigate the chief complaint. We're going to utilize OPQRST and sample and look at your pertinent negatives. We're going to instruct the patient to keep still and not to move their head or neck. And we're going to do a systematic head to toe full body scan as well. We're going to obtain a complete baseline set of vitals. Significant head injuries may cause the pulse to slow and the blood pressure to rise. These patients that have head trauma, consider them critical. Give vitals every 5 minutes. When neurogenic shock kicks in, the blood pressure may drop, and the heart rate may increase to compensate. So respirations may become erratic. So we want to use our monitoring devices that we have readily available to us, right? So cardiac monitoring, things like that. Remember that when you're performing your full body scan, use your DCAP BTLS and examine the head, chest, abdomen, and extremities in the back. We're going to check perfusion, motor function, and sensation in all extremities prior to moving a patient. Those are your CSMs, right? Circulation, sensory, motor function. What is DCAP BTLS?
Deformities,
Right?
Deformities, contusions, abrasions, punctions, punctures.
Burns,
Yep. What's TLS?
tenderness, lacerations, and swelling.
Awesome. Sean got it all in there too as well. Good job, guys. Love it. So a decreased level of consciousness is the most reliable sign of a head trauma or head injury. We also want to look for leaking blood or CSF, so take a look for that. We're going to assess pupil size and reaction to light and continue to monitor the pupils. Pupils need to be perla, P-E-R-R-L-A. Pupils equal, round, and reactive to light and accommodation. Do not probe the scalp laceration with your gloved finger. Please don't stick your finger in the hole, right? Bad things can happen with that, right? If you see an opening, let it be, bandage it, and move forward. Control the bleeding. We're going to perform a baseline assessment using our Glasgow Coma Scale. How is that measured? What are the 3 parts of a Glasgow Coma Scale?
first one's eye,
Yep.
Response to verbal and response to pain.
So motor function. So eye opening, verbal response, motor function. What's the highest score you can get in a GCS?
$15.
Yep, 15 it is. And what is the lowest score you can get? No,
I
not
think
8.
3.
3. So 3 being the lowest, 15 being the highest, right? There used to be an old saying, less than 8 intubate. Any patient that is altered, even dementia patients have a GCS of 14 because they're considered confused. Right? So when you're doing your GCS scores, okay, when you're doing your testing and you say, yeah, a GCS of 15, you better make sure that you know what 15 actually is. Look for these patients. Trauma patients have to have a GCS score. Medical patients have to have a GCS score. Documented in your narrative. It's going to be in your vital signs section of your burn reports as well. Document everything. If you have a deviation, I'll show you the next slide, of the Glasgow Coma Scale, you want to make sure that you document where the deviation was. You tell me they have a Glasgow Coma Scale or GCS of 13, what makes it 13? Right? So let me know which ones they are. We're going to do a spinal examination looking for DCAP BTLS. If there is impairment, note where the level of impairment is located. If there's pain or tenderness when you palpate the spinal area, this is called a warning sign that there is possibly an injury there. Other signs and symptoms include deformity, numbness, weakness, tingling of the extremities, and soft tissue injuries. Then we're going to do our repeat assessment, repeat the primary, reassess vitals, reassess the chief complaint. Remember, your chief complaint can change. Recheck the patient interventions that you've done. These injuries also can suddenly affect the respiratory, circulatory, and nervous system, and you want to reassess these patients at least every 5 minutes. All right. As far as multiple interventions may be necessary in patients with head and spinal trauma, so you may have to prioritize which one needs to be done first. You want to compare baseline vitals and repeat vital signs as well, and changes will often tell you if treatments have been effective. So again, this is called getting your baseline, and then you something called trending. You want to make sure it's trending in the right direction. You must act quickly to evaluate and treat these patients, okay? If CSF is present, cover the wound with a sterile gauze, but do not bandage tightly. It is leaking out for a reason. That could be because of either a fracture or increased intracranial pressure. That's how it's relieving pressure. Administer high flow O2 and apply a cervical collar. Your documentation should include the history that you obtained at the scene, your findings, your treatments, how they responded, and how often you perform vitals. Now, as far as emergency medical care, there are 3 general principles. 1, establish an adequate airway. 2, control bleeding. CPR if necessary, follow standard precautions. All right. And assess the patient's baseline level of consciousness and continuously monitor. If it gets worse, the patient's starting to deteriorate. If it gets better, the patient's starting to improve based on your treatments. Manage the airway. Trauma patients require a jaw thrust maneuver. Once the airway is open, maintain the head and cervical spine in a neutral inline position until you have placed the cervical collar on the patient and secured the patient onto a board to get them off the ground. As you can see here, they are applying a cervical collar, which we will cover in class. We're going to remove any foreign bodies, secretions, or vomitus. If they vomited, suction it out, remove it. Check ventilation status, and give supplemental O2. CPR if needed. Active blood loss aggravates hypoxia. Remember, if you lose blood, we have nothing for the red blood cells to attach to and float through. Therefore, they lose that ability to transport oxygen. All right. So keep that in mind when you're looking at your assessment. What is their blood pressure? Shock is usually a result of hypovolemia, which would indicate a serious situation, and the patient is now critical. You want to transport to a trauma center. All right, we've already talked about Cushing's triad. To perform controlled hyperventilation of your patients via positive pressure ventilation at a rate of 20 breaths per minute. Now, 20 is on the high end for an adult, but within our normal limits between 12 to 20. We're going to follow standard precautions. We're going to maintain the patient's airway, and we're going to assess respirations and give supplemental O2. And with a jaw thrust, have suction ready. All right, patients that have head trauma, get the suction out, attach it to your wall mount, your home suction, and get ready to go. All right, this is a jaw thrust maneuver. Hands along the jaw line. We kind of lift up and displace the jaw. We're going to immobilize the cervical spine utilizing a cervical collar. And we're going to immobilize the patient in their current condition. If they're lying on the ground, we immobilize on the ground. If they're sitting in a car seat, it's on a car seat. If they're standing, we put it on while they're standing. All right? In the position you find them is the position you want to place your cervical collar. We're going to provide, 3 collars provide preliminary and partial support. It should be applied to every patient who has a possible spinal injury based on their MOI, history, and signs and symptoms. To be effective, it has to be a rigid collar and it has to be appropriately sized, which I will show you guys to do on your practical day. It should rest on the shoulder girdle, and provide firm support underneath both sides of the mandible without obstructing any area of ventilation. Cervical collars have openings for the trachea to be assessed and the C-spine to be assessed. There's openings in the front and back. So it allows you guys to be able to see what's going on if there's any deviations or changes. Supine patients secured to a longboard or a vacuum mattress. Another procedure is to move the patient by a backboard with a four-person log roll. So I'm going to show you guys the log roll. The scoop stretcher works even better because you don't have to roll them or move them. You also slide the patient onto a backboard or a vacuum mattress. We do not have vacuum mattresses around here. Very, very popular out west, but not around here as much. This is an alternative way to other than using a longboard. That's all that is. So for sitting patients, they want you to use a short board or a short backboard to restrict motion movement. They also can utilize a KED. We don't really keep these on the ambulance anymore because they're not required. We've kind of gotten away from the sit-up because we can usually stand them up. We can turn and sit, keeping everything in line. Standing patients mobilized to a longboard before proceeding with an assessment. Again, if they're standing, bring the stretcher to them, have them sit, and in one motion, turn and lie down. Carefully lower the patient until the unit is under direction of the EMT at the head with the boards. All right. Other things you can utilize is manual inline stabilization or a cervical collar and a long backboard. This next slide here I'm showing here is a KED. This is called a Kendrick extrication device, which is a vest type device that goes around the waist, underneath the armpits, and secures the head and goes through the crotch. And then when you pick them up, you lie them down, unbuckling the crotch straps, leaving the KED in place, and you put them onto a board and you transport to the stretcher, then you load and go. These are longboards, which provide full body immobilization. Again, you need to have enough straps to do so. Longboard testing is no longer a test within the National Registry because they've gotten rid of it. So it's all done in-house, internally. All right. So a helmet that fits a person well prevents the patient's head from moving and should be left on provided there are no impending airway or breathing issues. It does not interfere with assessment and treatment of your airway or ventilation problems, and you can properly mobilize the C-spine. So we're going to cover how to remove helmets in our next practical session. But the helmet, remove the helmet if it's a full face shield where you can't assess the face, if it makes assessing or managing airway problems difficult, prevents you from properly immobilizing the C-spine or the spine, and allows for excessive head movement, and the patient's in cardiac arrest. So I'll show you some different techniques with towel rolls to kind of work with this as well, keep their spine safe and in line. So removing a helmet should always be the job of at least a two-person job. You should never take them off alone. We'll cover that, like I said, later. The alternate method is the advantage that it allows the helmet to be removed with the application of less force, therefore reducing the likelihood of motion occurring in the neck. They do make devices that are out there that are inflatable that you can slide it up the back side of the helmet. It goes to the top of the head, you inflate it like a blood pressure cuff, and it pushes it off the head for you. So there are other methods that are out there as well. Alternate method would be removing the face mask, a chin strap, pop the jaw pads out of place, place your fingers inside the helmet, hold the jaw with one hand and the occiput with the other, or in padding behind the occiput as well. All right, last slide here. So the person at the side of the patient's chest is responsible for making sure that the head and neck do not move during helmet removal. All right, we'll talk about, like I said, we'll talk about this later on. So let's do some review. We'll take 10 minutes, come back, and we'll finish up. Well, the next presentation is actually pretty short, so it won't be too bad. The brain, a part of the central nervous system, is divided into the All right. A it
See.
is.
Oh, shit.
All right,
Sorry,
number two.
language.
It's okay for all adults. Unless there's kids listening. Even still, for all adults. All right. As you are assessing a 24-year-old man with a large laceration to the top of his head, you should recall that all right, very good. B it is. A patient who experiences an immediate loss of consciousness followed by a lucid interval has what? Immediate loss of consciousness right away. So immediate would be something severe, right? The epidural hematoma is more severe than a subdural. Epidural is a arterial bleed. So A. A 44-year-old man was struck in the back of the head and was reportedly unconscious for approximately 30 seconds. He complains of a severe headache and is seeing stars and states that he regained his memory shortly before your arrival. His presentation is mostly consistent with perfect concussion. A young male was involved in a motor vehicle accident and experienced a closed head injury. He has no memory of the events leading up to the accident, but remembers that he was going to a birthday party. What is the correct term to use when documenting his memory loss? Very good, retrograde amnesia. A distraction injury to the cervical spine would most likely occur following what? Distraction injury. All right. D. Excessive traction of the neck, like a hang type mechanism. During immobilization of a patient with a possible spinal injury, manual stabilization of the head must be maintained until this is a tough one because New Hampshire doesn't do this anymore.
B.
So the answer for National Registry is B. When the patient is fully immobilized onto a longboard. Right. We don't do that anymore. That's not something that New Hampshire or Maine does. Right. We don't have to hold C-spine if they're on a board as long as they have a cervical collar in place. But National Registry is B. Your patient is a 21-year-old male who has massive face and head trauma after being assaulted. He is lying supine, is semi-conscious, and has blood in his mouth. You should do what? Read your answers
B.
carefully. This is a National Registry question.
B.
The answer is C. Manual stabilization of the head, log roll into the side, and suction the airway. Right? Airway before cervical spine. Right? And you have to turn, and anytime you have a patient that's vomiting or blood in the airway, you got to turn them onto their left or right side, or there it actually leaks out. Suction, clean out his airway, and you can roll him back and get your cervical collar in place. But if his airway is clogged and blocked, he will die from hypoxia. Or they'll aspirate that vomit or blood into the lungs, causing even more issues like infection. A man is found slumped over the steering wheel, unconscious and making snoring sounds after an automobile accident. His head is turned to one side, turned to the side, and his neck is flexed. You should do what? Everybody's talking about applying an extrication collar, right? Remember, his head is turned to the side, so a collar will not work for this patient until you manually put it back into a neutral inline position. Here's the kicker. As you are doing this, the answer is D, right? Make sure that you're actually feeling for any kind of crepitus or cracks. And if the guy has significant pain turning his head back to neutral, don't force it if it won't go, all right? And you want to stabilize it in that position by using towel rolls and everything else. If you force it back to the position it needs to be in, you could pop something and actually sever the spinal cord. You should not remove an injured football player's helmet if. Should not remove. All right, D it is.
This conference will now be recorded.
All right, chapter 29, chest injuries. All right, so we're going to talk about chest trauma, blunt versus penetrating, impaled objects, open chest wounds, pathophysiology, blunt versus penetrating mechanisms, hemothorax as well. We're going to talk about the management of a pneumothorax with the open, simple, or tension. Cardiac tamponade, rib fractures, flail chest, commotio cordis as well. So each year in the United States, chest trauma causes more than 700,000 emergency department visits and more than 18,000 deaths in the United States. Such injuries can involve the heart, lungs, and great blood vessels. So this may be the result of blunt penetrating trauma or both. And we'll go more in detail here in a moment. Immediately treat any of these injuries that interfere with normal breathing functions, right? Internal bleeding can collect in the chest cavity, compressing the lungs and heart as well. The air may collect in the chest cavity, preventing the lungs from expanding. So let's go more in depth in this here. We'll go to A&P review. Remember that the difference between ventilation and oxygenation. Okay, ventilation is the body's ability to move air in and out of the chest and lung tissue. Oxygenation is the process of delivering oxygen to the blood by diffusion. Remember, it's a gas, so it's diffusion through the alveoli, following inhalation into the lungs. So injuries affecting the patient's ventilation or oxygenation are serious as well and may be life-threatening. So over the chest, the thoracic cage extends from the lower end of the neck to the diaphragm. So a penetrating injury to the chest may also penetrate the lungs and diaphragm and injure the liver or the stomach as well. So let's take a look at the thoracic skin, muscle, and bones, which have similarities to the skin, as you can see through here. On my screen, it is super tiny and small. It's hard to even see it. But as you can see, the subclavian artery runs through the clavicle. So subclavian, clavicle, heart located here, superior in vena cava, being the deoxygenated blood, That's why it's in blue. The aorta runs down the middle through here. 2 lungs, the pleural lining, which runs around the lungs itself, and the diaphragm being located here, right? So also unique features allow for ventilation, such as the strained muscles or straighted muscles. That allows Russ to take a deep breath in and back out again. And excuse me. So intercostal muscles, which extend between the ribs. So the rib cages would be located here. We have intercostal muscles. Not yet developed in very young children who tend to breathe from the diaphragm. That's why we have belly breathing. So our intercostal muscles help assist us to breathe, inhalation, exhalation. So innervated from the spinal nerves as well, allow the chest to expand on contraction and the active portion of ventilation to occur with that. So the neurovascular bundle is a network of nerves, arteries, and veins lying closely along the inferior and slightly posterior to the lowest margin of each rib. This can be a source of significant bleeding into the pleural space. And I'll show you guys on the next slide the pleural space and what we're talking about. The pleura covers each of the lungs in the thoracic cavity. The parietal pleura is the inner chest wall lining. The visceral pleura covers the lungs. And then a small amount of pleural fluid between the parietal and the visceral pleura allows the lungs to move freely against the inner chest wall as the person breathes. So during respiration. So if you look at this slide here, the vital organs of the heart are protected by the ribs, connected in the back to the vertebra and connected to the front. So as you can see, the rib cage is here. Things we need to look for in the chest trauma as we're doing our palpations. Remember that when I mentioned before, we're doing our assessment, take your fingers and your hands underneath the breasts of a female or pectorals of a male, spread your hands apart nice and wide and wrap around the rib cage and have them take a deep breath in and out, okay? This allows us to get a good full palpation of those ribs. Then you want to palpate going from the first rib down each side to make sure they're all still intact. All right, every space you feel, like indentation, is what they call intercostal space. And those are going to be very important to also know, kind of as off topic for cardiac, on your 12 lead placement. Hold on one second. All right, sorry about that. So the ribs are connected in the back to the vertebra and in the front to the sternum. So it kind of wraps around. We do have some floating ribs that are down a little bit lower. The trachea divides into left and right main stem bronchi, which supply air to the lungs. So I can bring up my little laser pointer here. All right. So trachea comes down, branches off, and so trachea, right and left main stem bronchi, into the bronchioles, into the alveoli throughout the whole entire lung. All right. So the thoracic cage, which connect from vertebra to sternum, protect those lungs. That's the point behind it. It contains the heart and the great vessels of the aorta, the right and left subclavian arteries, as well as their branches, the pulmonary arteries, superior and inferior vena cava, all those great vessels, the lungs, all this stuff is protected by this rib cage, right? Our ribs are fairly strong, however, they can fracture. And when they can fracture, they can become very sharp, and they can also cause significant punctures as well. They can do a lot more damage to our protected area, right? That's why it's so important to make sure we do a good assessment and visualize what we're looking at, not just palpate through the shirt, but getting them that trauma naked that I keep bringing up, because you want to be able to pick up on significant bruising. You want to be able to look at flailed chest, feel for flailed chest, palpate for the crepitus, and go right down through and note where these things are. Right? The mediastinum is the central part of the chest containing the heart, great vessels, esophagus, and trachea. This location is where the thoracic aortic dissection can occur, which is a severing of the aorta that can occur when the body is exposed to traumatic force. Right? We talked about that side impact, rotational spins, things like that, and motor vehicle accidents as well, that can cause the force to sever the aorta located where the mediastinum is. The diaphragm is a muscle that separates the thoracic cavity from the abdominal cavity. There's a diaphragm there, right, with that. So mechanisms of ventilation, remember the intercostal muscles between the ribs contract during inhalation. The diaphragm then contracts or then flattens at the same time, and the interthoracic pressure inside the chest decreases, creating a negative pressure differential. This is important to know, because this will go more in tail with a pneumothorax. So air then enters the lungs through the nose and mouth. The intercostal muscles and the diaphragm then relax during exhalation, allowing air to be exhaled. So remember, our system runs at negative pressure. All right, so the body should not have to work to breathe when in a resting state. Now, if we're injured, if we are running, if we are doing something that exerts ourselves, then we have to work a little bit harder to breathe. But if we're sitting down in a chair, resting, relaxing, we should not have to work to breathe. If we're working to breathe, then something is hindering that, whether it be a bronchoconstriction for medical terms, medical issues, to a traumatic event like a pneumothorax, a pulmonary contusion, some kind of traumatic issue that can cause us to have more difficulty breathing, right? So as you can see here, mechanics of this. So what you're seeing in this picture here shows a slide of the anatomy of the thoracic cavity during inspiration and expiration, right? So we have deflated lungs, right? So deep breath out, exhalation, lungs deflate, breath goes in, negative pressure, lungs start to inflate. So patients, this is where spinal cord injuries come into effect. So a patient whose spinal cord is injured below C5, okay, may lose the power to move intercostal muscles, right? C3, C4, and C5 keep the body alive, right? If we sever something in that area, spinal injury in that part, we can lose the ability to breathe. We can lose the ability for our heart to function appropriately. We can lose a lot of ability. Also, the inability to be able to move extremities as well. The diaphragm should still contract, but the patient will still be able to breathe because the phrenic nerves remain intact. The patient with spinal injury at C3 or above can lose the ability to breathe entirely. Remember I mentioned the C3, C4, C5. If we have a C3 issue, they're not going to be able to breathe at all anymore. And if you're looking at the photo over here, you can see where this controls everything that's in blue. All right. So it's amazing what the body actually does with that. All right. So mechanics of ventilation, to kind of finish off on this before we start getting into our injuries to the chest. The minute ventilation or minute volume is the amount of air moved through the lungs in 1 minute. This is calculated by multiplying the normal tidal volume of a patient's by a patient's respiratory rate. What is our normal volume? What would be our normal tidal volume? All right, Debbie, has anybody else got any answers to that? 500? Yeah, 500 ml normal tidal volume. So looking at a BVM, a 1,000 to 1,500 ml bag valve mass might actually overinflate the lungs, causing gastric distension and impaired lung function. gastric distension, inflation of the stomach, all right, puts pressure against the diaphragm, causing the lungs not to expand, the heart not to pump effectively. And this is caused by overinflation or providers that ventilate too fast or put too much air. So what we're looking for is just enough of the BVM to look for chest rise. Once the chest has risen, we have got the patient is being oxygenated enough with ventilation and air. All right. Overventilation can increase that interthoracic pressure. Additionally, if people are bagging too fast, remember it's one breath every 6 seconds, right? If we're doing one every 3, one every 2, we're bagging quick because we're in a cardiac arrest, or we have a patient who's not breathing effectively, and we're bagging really fast because we're a new provider. This can also cause acid-base imbalance and a blood gas imbalance as well. Now we're over-oxygenating this patient, which we should not be doing, not allowing for correct carbon dioxide exchange. All right, so you got to slow the respirations down. All right, so there's two types of injuries to the chest: open and closed. A closed chest injury, obviously the skin is not broken, generally caused by blunt force trauma. So this can cause significant cardiac and pulmonary contusions. So bruising to the heart, bruising to the lungs. If the heart is damaged, it may not be able to refill with blood, or blood may not be able to be pumped with enough force to the heart, resulting in cardiogenic shock. Lung tissue bruising can then also result in exponential loss of surface area, which then leads to decreased oxygen and carbon dioxide exchange. This can cause hypoxic and hypercarbic states, so high carbon dioxide, low oxygen. Rib fractures can lacerate the lungs and cause further vessel damage with every chest wall movement, and this can rapidly deteriorate to hypovolemic shock. So they're talking about closed injuries, heart swelling, and then I say cardiac tamponade, right? So how do we find cardiac tamponade? All right, I got JVD. What else? Muffled heart sounds, yeah, and there's one more. How do we find cardiac tamponade? That was the question.
Is narrowing pulse pressure is one of them?
It is. Yep, that's one of the three. And then I'm looking at the chat box as well. And it's JVD was the other one, and muffled heart sounds. All right. So I want to make a quick mention as well. Hopefully everybody's listening. On Sunday, please do not use the chat box. You guys actually have to talk. Dave has a hard time trying to separate the chat box like I do. I've shown him how to do it, but he prefer everybody actually talk to each other. So you're probably gonna have to come unmuted most of the time. So please try to make that accommodation for him. All right.
Sounds good.
Cool. Awesome. All right. So in an open chest injury, the object penetrates the chest wall, like a knife, bullet, piece of metal, broken end of a rib. So do not attempt to remove the object. Leave it in place, right? Because it may cause more damage if you remove it. So stabilize it, secure it, and then transport it. Now, if the object is like 8 feet long, you're going to have to cut the object down. Just remember that as you're cutting these objects, the vibration can cause significant pain. So you may want to get paramedic on board definitely to get pain management to help maybe sedate them enough so you can do that. So blunt trauma to the chest may fracture the ribs, sternum, and chest wall, bruise the lungs and the heart, and even damage the aorta. We talked about this already. right? Almost 1/3 of the people killed immediately in a car crash dies as a result of a traumatic rupture of the aorta. 90 seconds, you can bleed out pretty quickly. So vital organs can be torn from their attachment in the chest cavity, causing internal life-threatening bleeding as well. Remember, solid organs are very vascular and can bleed very quickly and can bleed a lot. Hollow organs, not so vascular as solid organs, but they have contents that do not belong in the abdominal cavity or the chest, right? So again, those rupture, significant infection. Signs and symptoms of chest injury is pain at the site of the injury, pain localized at the site of the injury that is aggravated or increased with breathing. All right, so broken ribs will cause someone probably to breathe pretty shallow. The drawback with shallow respirations means they're not moving enough air and there's too much air sitting in dead space, and that can cause stale air to stay inside, and that can cause an infection like pneumonia. Bruising to the chest wall, crepitus on palpation of the chest, any penetrating injury to the chest, dyspnea, which is difficulty breathing, can also be caused by airway obstruction, damage to the chest wall, or improper chest expansion or lung compression. So prompt, vigorous support of oxygenation ventilation with prompt transport is required. You have to know when you need to pick up on these, when you might need to actually put a BVM on someone who's currently breathing, and actually ventilate for them. Other things would be hemoptysis, so bloody vomit, or spitting or coughing up blood, which indicates damage to the lung or air passage. Failure of one or both sides of the chest to expand normally with inspiration, rapid weak pulse, low blood pressures, or principal signs of hypovolemic shock. Remember, heart has to go faster to bring oxygen around through red blood cells, which then makes you tachypnic, fast breathing, to bring oxygen in from the air. It's our body's mechanism of saying, hey, I'm trying to keep you alive. But it can only go on for so long before the body actually starts decompensating and becomes irreversible. Cyanosis around the lips or fingernails are signs of inadequate respiration, and immediate ventilation oxygenation is required. Pulse oximetry is a tool, right? But cyanosis doesn't lie. If they do not have oxygen in the cells, you will start turning blue. All right, patients with chest injuries often have tachypnea, rapid respirations, or shallow respirations, rapid shallow, because it hurts for them to take a deep breath. The patient may not actually be moving air due to the chest wall trauma, so auscultate in multiple locations of the chest wall to assess for adequate breath sounds. You need to check lung sounds. Get your stethoscope, listen to the chest, not just upper, but upper and lower, right? Because if you're absent, most likely could potentially be a pneumothorax or a collapsed lung. So let's look at scene safety. Ensure your patient is safe. Make sure your partner is Make sure your partner is safe as well. And make sure you're using gloves. Look at the mechanism. All right. Chest injuries are common in motor vehicle crashes, falls, industrial accidents, and assaults. To determine how many patients there are and consider a C-spine. Formal general impression. A lot of this stuff is going to be reviewed again with a couple added features. Note level of consciousness using your APGAR scale, and do your rapid assessment. Obvious injuries, appearance of blood, difficulty or irregular breathing, and cyanosis. Perform a rapid scan, looking for chest rise and fall only on one side. If you see that, it's a pneumothorax. Right? Accessory muscle use, looking at your accessory muscles. Extended or engorged jugular veins. Right? If you have JVD, you got to think about tamponade. Right? Assess ABCs, overall appearance. What do they look like? How do they look to you? What is their normal? All right? If they're pale, diaphoretic, and clammy, they're in shock. Right? High flow oxygen, treat for shock, keep them warm. Right? Continue doing your assessment. Make sure they have a patent airway. If it's clogged, suction it out. Right? You got vomit in there, clear it. Consider early cervical mobilization. If they're distended jugular veins, consider tamponade. Is the breathing present or is it adequate? And look for decap BTLS. Look for equal expansion of the chest. Your documentation should show equal rise and fall, okay? If it's unequal, look for that paradoxical motion. Is one side going up, one side not, right? Apply occlusive dressings to all penetrating injuries, right? If the penetrating injury and it's not an object still impaled or sticking out, you need to cover it with an occlusive dressing and support ventilations. So I'm going to ask you guys this really quick. What is an occlusive dressing? And how do you
A
apply it?
steel barrier, get it some sort of adhesive
Yep.
to what? Sometimes a pneumothorax would be 3 inches or 3 sides.
Yep. Why is that though?
Let air out.
To be able to let air out but not suck air back in, right?
Right. So but only in a pneumothorax would you do a 3-sided, right? So a fully occlusive dressing would be 4-sided, right?
Correct. Yep. So you want to prevent air from going in, but air still has to be able to come out. And then the other occlusive dressings will be for all type, all 4. So we want to make sure that we all right. Support ventilations, apply O2, apply a non-rebreathing mask of 15 liters. If breathing is inadequate, then we have to go to positive pressure ventilation. All right, now make sure we're treating our patient. There we go. All right, I'm gonna turn some lights on here. There we go. All right, when we're doing our primary assessment, we're going to reassess the effectiveness of the ventilatory support. Right? Are we seeing our changes? Is the hypoxia getting better? Is the oxygen saturations going up? Is the patient starting to pink up? Right? But be alert for impending tension pneumothorax. Circulation, rate, rhythm, and quality. Look for the skin color and temp, and assess any or address any life-threatening bleeding immediately by using direct pressure and a bulky dressing. Right? We're not going to be able to apply tourniquets to chest wounds. Right? So direct pressure, bulky dressing, tape, and then make sure you wrap it in nice and tight. Priority patients are those who have problems with ABC. So pay attention to the subtle clues. Appearance of skin. Is it pale, cool, clammy, diaphoretic? Level of consciousness, utilizing your AVPU scale. Alert, verbal, painful, unresponsive. A sense of impending doom in the patient. They say, I'm going to die. If they start saying that to you, you may want to take note of that because they probably will. A delay in the scene to perform a lengthy assessment will reduce the chance of survival in a patient. Trauma patients, you need to consider the golden hour and the platinum 10. The platinum 10 is the first 10 minutes on scene. You need to make a decision on what you're going to do. The golden hour is the time the injury started to the time they get definitive surgical care. With chest injuries, when in doubt, transport rapidly to a hospital. This right here in table 29-1 is called the deadly dozen chest injury. Chest injuries. Airway obstruction, bronchial disruption, diaphragmatic tear, esophageal injury, open pneumothorax, tension pneumothorax, massive hemothorax. So a hemothorax is blood in the lungs. A pneumothorax obviously is the collapsed lung, and you can have a hemopneumo. You can have both. Flail chest, cardiac tamponade, thoracic aortic dissection, myocardial contusion, so heart contusion, or pulmonary contusion. Right, this is called the deadly dozen. So we're going to further investigate the MOI, identifying signs and symptoms of pertinent negatives, utilizing a sample history, looking at the basic evaluation should be completed, and a focus on the MOI. All right, so we're looking for pertinent negatives, like no associated shortness of breath, no rapid breathing, no absent or abnormal breath sounds, no areas of deformities or abnormal movement, equal expansion to the chest and the movement of the rib cage and the diaphragm. Confirm that the nerve conduction to that region of the body as well. You got to utilize your sample history. What is sample again? So what is your sample history?
Signs and symptoms, allergies, medications, pertinent past medical history, last oral intake, events leading up to injury or illness.
Perfect. I like it. All right, so a physical exam for isolated injuries, focus on the isolated injury itself, the patient's complaint, the body region affected, and ensure that wounds are identified and bleeding is controlled. So if they're bleeding, control it, put a bandage on it and move forward, right? Location and extent of injury. Look, find out where it is and where it's going. If it's a penetrating injury, what potentially could be underneath there that could be damaged? This is why it's so important to have your A&P down, right? Assessment of the underlying systems. So palpate, vital signs, lung sounds, things like that. Take a listen to abdominal sounds as well. Changes in the patient's ability to maintain adequate respirations. Things can deteriorate pretty quickly, so you need to make sure you're on top of your patient all the time, right? Further assessment, monitoring pulse ox, right? Looking at end tidal, waveform capnography. For significant trauma likely affecting multiple systems, start with a rapid physical exam, utilizing DCAP BTLS. These are your head to toe 90-second exams. You need to find anything life-threatening and treat it. Vital signs, this activity should include assessment of the pulse, respiration, blood pressure, skin condition, color, and temperature, along with pupils. These patients need to be reevaluated every 5 minutes because later stages in this can actually cause the patient to deteriorate and change quickly, right? So with this, the patient can have a decrease in available oxygen or hypoxia, or blood loss resulting in decreased red blood cell count, which is what they call hypoxemia. So low oxygen count in the blood versus low oxygen coming in. Increased work of breathing identified by accessory muscle use in the face, neck, and chest. Pulse and respiratory rates may decrease in later stages of a chest injury. If they're decreasing, we're in decompensated shock. The myocardium becomes starved for oxygen and the body can no longer keep up with the demands. It can also cause significant cardiac injury as well. And the brain becomes starved for oxygen and then overloaded with carbon dioxide and other waste products, puts the patient in a very acidotic state, and the patient can go into cardiac arrest. So we're going to repeat our reassessments. We're going to reevaluate airway, breathing, circulation, perfusion, skin color, and temperature. Look at that perfusion in these trauma patients. Get a cap refill, right? These are important findings on your assessment. Then major any kind of bleeding, right? If you are applying occlusive dressing, make sure it's still intact, right? Reassess it. Reassess vitals and observe any trending. You have to do vitals every 5 minutes, right? Maintain an open airway. Control significant visible bleeding, right? Place an occlusive dressing over penetrating trauma to the chest wall, right? This should be noticed as sucking chest wound and bubbling. For patients with signs of hypoperfusion, provide aggressive treatment for shock. Lay them down, right? Make sure that you distribute their load across their body. Keep them warm, right? For some patients, raise their legs. It's old school, but it's called Trendelenburg, but it brings blood back to the core, right? There's other methods. Oxygen therapy. Put them on a high flow oxygen or BVM if you need to, right? Describe all the injuries and treatments given. Communication is very important. All right, so let's talk a little bit about more of these things we're going to find. Commonly called a collapsed lung is called a pneumothorax, which is the accumulation of air in the pleural space. Air enters through a hole in the chest wall or the surface of the lung, therefore causing the lung to collapse. Air is now expelling out, lung is starting to collapse. The patient's attempt to breathe causes the lung on that side to collapse down, so blood passing through the collapsed portion of the lung is now not oxygenated. Therefore, breath sounds will be affected on one side, indicating different conditions. It could be diminished or absent lung sounds. If the lung is past 30 to 40%, you may hear diminished breath sounds. Now, you may have a pneumothorax and not even pick up on it. It could be a slow leak that they can only pick up in an x-ray, right? So if you miss it and it's very minor, don't beat yourself up over it, right? It's the big ones, the absent lung sounds, those big new ones, greater than 30 to 40%. A sucking sound on inhalation and the sound of air rushing on exhalation indicate the chest wall has been penetrated. As you can see in this picture here, right? So you have the wound site located where my dot is located here, and you have air in the pleural space causing that negative pressure system not to work. Therefore, the lung is not going to be able to inflate properly or at all, therefore causing that definition of pneumothorax. You're going to see decreased respiration, so have chest pain on that one side, and a very, very late sign, the trachea located here will deviate to the side that actually works. If you see tracheal deviation, that is a very, very late sign. So the pneumothorax open chest wound often causes a sucking chest wound, must be sealed with an occlusive dressing, and a flutter valve is a one-way valve that we can utilize. So this way here, air only goes in, but doesn't come back. I'm sorry, only comes out, but doesn't go back in. Right, so carefully monitor the patient for a tension pneumo. And then follow your local protocols. This is another illustration here of a sucking chest wound as air passes through the pleural space. So a simple pneumothorax does not result in major changes in the patient's cardiac physiology. Right, commonly the result of blunt trauma that results in rib fractures. This will decrease breath sounds associated with significant lung collapse. So the signs and symptoms would be dyspnea, increased work of breathing, and an increased respiratory rate. Tachypnea and accessory muscle use, decreased oxygen saturation, a crackling sensation felt on palpation of the skin is what they call subcutaneous emphysema. Late findings are going to be decreased breath sounds on the injured side, lethargy, cyanosis, and a very, very late sign is tracheal deviation. Be vigilant because simple pneumothorax can worsen, deteriorate into a tension pneumothorax or develop complications like bleeding or a hemothorax. So as far as treatment at the BLS level is high flow oxygen, monitor pulse ox, treat the underlying injury. Do not withhold positive pressure ventilation if the patient needs support. Right? This may cause a tension pneumothorax, so have a plan to resolve complications. Our plan, get a paramedic on board so they can do a needle decompression. So a tension pneumothorax is a result of ongoing air accumulation in the pleural space. This air then gradually increases the pressure in the chest, causing a complete collapse of the unaffected lung. The mediastinum then is pushed onto the opposite pleural cavity, where blood cannot then return through the vena cava to the heart. This then decreases cardiac output, leads to shock, ultimately results in death. Tension pneumothorax is commonly caused by blunt injury, in which a fractured rib lacerates the lung or bronchus. Common signs and symptoms are going to be chest pain, tachycardia, marked respiratory distress, absent or severely decreased lung sounds on the affected side, hypotension, altered mental status, jugular vein distension, cyanosis, tracheal deviation, and all we're going to do at the EMT level is provide high flow oxygen. Request ALS immediately because a needle decompression may be performed. All right. These patients ultimately need to have a chest tube placed in the OR. All right. This is showing attention pneumothorax here. Because now the lung is completely pressed down, ton of air inside the pleural space, forcing, as you notice, the diaphragm was straight down here, right? We're starting to see that shift, diaphragmatic shift, causing significant pressure on the heart, therefore it can no longer pump, and more pressure on the other lung itself. So a hemothorax is a condition in when blood is collected in the pleural space from bleeding around the rib cage or from the lung of the great vessel. Right. The only way to tell if it's a hemothorax really is if they do a decompression, blood is going to squirt out of the needle. This is done by bleeding in the chest wall. So as you can see, the hemothorax here, blood starting to fill up from the bottom of blood in the pleural space, filling up the lung. So air on top, blood down low. Signs and symptoms would be shock without any form of obvious external bleeding or apparent reason for shock. Like, well, where are they bleeding from? It could be a potential hemothorax. You'll have decreased lung sounds and a pneumothorax, the presence of air and blood in the pleural space. So again, the only treatment we're going to do for this is rapid transport. These patients need chest tubes. They need them quick. So if you have a motor vehicle accident, they're trapped, the best option for these patients here are getting life flight, because life flight dart, they can do chest tubes in the field as well. All right, so they may place a chest tube in the back of the ambulance or in a helicopter before they go. Cardiac tamponade is a protective membrane, the pericardium around the heart, which then fills with blood or fluid. So we talked about, I don't remember if I saw this in here at all. I don't think I did. We talked about the 3 indications of cardiac tamponade, right? What triad is that called?
Beck's triad.
Perfect. That's it. And Nick got it online as well. Beck's triad. Good. This illustration shows cardiac tamponade, as you can see on the pericardium, the outside layer. Remember, endocardium, myocardium, pericardium. Pericardial tamponade, right, causing pressure on the heart. Heart cannot pump effectively, causing the narrowing pulse pressures. The only solution to fix this is getting them to a hospital, right? They need something called a pericardial centesis done, which is a very, very long needle guided by ultrasound going into the pericardium, pulling out the fluid. So Beck's triad. All right. So with this here, support ventilations, we're going to transport rapidly. Rib fractures, common, particularly in older people from a fall, things like that. A fracture of one of the upper 4 ribs is a sign of a very substantial mechanism of injury, right? The upper 4 ribs are very well protected. They're very solid. A rib fracture also can cause a pneumothorax, hemothorax, or a hemopneumo. So we're going to go to the next slide here. With signs and symptoms of this, we localize tenderness and pain when breathing, rapid shallow respirations, a patient holding the affected portion of the rib, and pre-hospital treatment includes supplemental oxygen. So take a look at this right here. We look at our ribs. If you have 2 or more continuous ribs broken, that's what they call flail segment, okay? What's going to happen is the detached portion of the chest wall moves opposite the normal, which would be paradoxal motion. So during during exhalation, out during exhalation, and the paradoxal motion is a late sign of flail segment, all right? So you're going to be able to see the indentation and the movement of those 2 ribs being broken. You got to be very careful with that as well, because those can actually become very sharp and actually puncture a lung. Pre-hospital treatment for this would be maintain airway, oxygen, support, and ongoing assessment. The only thing that ALS is going to do for this is they're going to provide airway. They're going to provide pain management for them. help him breathe better. Treatment would include positive pressure ventilation with a BVM. You want to try the best to restrict chest wall movement. But again, we're not going to hold it back. This is no longer recommended. We want chest wall to move, but we don't want it to move too much to the point where it actually can cause a punctured lung. So again, I mentioned sandbags on an ambulance back in the late 90s. That's what we used to do, is put sandbags on the chest to kind of support, to make sure the lungs didn't expand as far, restricting motion. And then they used to wrap chests with ace bandages and things like that to restrict the motion. That was actually causing more damage. A pulmonary contusion should always be suspected in a patient with a flailed chest. So pulmonary alveoli become filled with blood, leading to hypoxia. So you're going to be able to pick up on that as well. So pulse oximetry, cyanosis. The only treatment we're going to be able to do in the back of the ambulance is going to be supplemental O2 and provide positive pressure ventilation as needed. Other fractures would be external fractures, which create increased index suspicion for organ injury. Remember, your sternum is very strong bone, and it should not be breaking. Clavicle fractures, very common. Possible damage to the neurovascular bundle, and suspect upper rib fractures and medial clavicle fractures as well. And be alert for a pneumothorax development. What you're going to feel for around the clavicle is air buildup up top, and you're going to feel like a Rice Krispies type feeling underneath the skin. It's going to pop, right? That's what they call the subcutaneous emphysema. Traumatic asphyxia, characterized by distended neck veins, cyanosis in the face and neck, and hemorrhage in the sclera of the eyes. So traumatic asphyxia, which is a sudden, severe compression of the chest, suggests underlying injury to the heart and possibility of a pulmonary contusion. We got to monitor vitals, and we got to get these patients to a rapid transport to a hospital. And they also need ventilatory support. The blunt myocardial injury is bruising to the heart muscle, where the heart may become unstable to maintain adequate blood pressure. Signs and symptoms would be irregular pulse rate and chest pain or discomfort. We're going to suspect this in all cases of severe blunt injury to the chest. Our pre-hospital treatment is carefully monitor the pulse, right? So throw these patients on a 12 lead, and that can help monitor pulse rates, all right? Note the changes in blood pressure and provide supplemental oxygen and transport immediately. All right, so commotio cordis. This is an interesting one, all right? This is an injury caused by sudden direct blow to the chest or a critical portion of a heartbeat. Right, it's what they call an R-on-T phenomenon, where the result is immediate cardiac arrest. VFib responds positively to defibrillation within 2 minutes of the injury. This phenomenon has been documented to have occurred after patients were struck with softballs, baseballs, bats, snowballs, fists, and kicks. More commonly associated with sport-related injuries, and should be suspected in all cases in which a person is unconscious, unresponsive after a blow to a chest, called commotio cordis. You guys ever heard that one before?
Is that how Houdini died?
I'm not sure. I have no idea how he died, honestly. But have you guys ever heard of commotio cordis before? No. I see Joy and Deb said no. So yeah, there's something to pay attention to. And this can happen to kids as well. They take a line drive to the chest. Pitchers, one of the biggest ones that get them. And it just drops into the ground. They're in cardiac arrest. Right? So don't think just chest trauma. They need to be defibrillated. All right, a couple more, one last slide here, and we'll start a review, and we'll get out of here for the night. So laceration of the great vessels may result in rapidly fatal hemorrhage, right? Pre-hospital treatment is a cardiopulmonary resuscitation CPR, ventilatory support, immediate transport, feeler for shock, and monitor for changes. The great vessels, remember, include the superior and inferior vena cava, pulmonary arteries, the four main pulmonary arteries, and the aorta, and its major branches. These are your great vessels you need to pay attention to as well. All right. With that being said, let's go over some review questions, and we'll call it a night. I know some of you still need to take your exam, so like I said, I would open that back up after people that had to work today. So the chest impacts the steering wheel during a motor vehicle crash with rapid deceleration. The resulting injury that kills almost 1/3 of the patients, usually within seconds, is called what? Rapid death. Yep, B it is, aortic shearing. Number 2, signs and symptoms of a chest injury include all the following. I should have said the word accept. Accept what? So you have hematemesis and hemoptysis. Hemoptysis is coughing up blood. Hematemesis is vomiting blood. So there's a difference, right? So the answer is going to be B. They're not going to be vomiting blood. They're going to have coughing up blood, which is different coming from the lungs versus the stomach. Yeah, no worries. It happens. So answer is B. During your assessment of a patient who was stabbed, you see an open wound to the left anterior chest. Your most immediate action should be to what? Yep, D it is. Cover the wound with an occlusive dressing. When caring for a patient with signs of a pneumothorax, your most immediate concern should be answer is C. All right. Number 5. What purpose does a one-way flutter valve serve when used on a patient with an open pneumothorax? Very good. B it is. Signs and symptoms. The signs of a cardiac tamponade include all the following except. Yep, C it is. A patient experienced a severe compression to the chest when trapped between a vehicle and a brick wall. You suspect traumatic asphyxia due to the hemorrhage into the sclera of the eyes. In which other sign? Traumatic asphyxia, loss of oxygen. The answer is B. Sudden increase in the intrathoracic pressure resulting in characteristic appearance. The number 8, a 14-year-old baseball player hit in the chest with a line drive. He is in cardiac arrest. What is the explanation? Correct. C. The commotio cordis. Paradoxal chest movement is typically seen in patients with very good whale chest. Last one, a 40-year-old man who was an unrestrained driver of a car that hit a tree at a high rate of speed. Struck the steering wheel with his chest. He has a large bruise over his sternum and irregular pulse rate of 120 beats per minute. You should be concerned that a lot of A's. Perfect. All right. Let me shut off the recording really quick.